Substance abuse amongst teens is increasing at an alarming rate. A group of advanced practice nurses from U of C 614 are on the case. This is Nurses and Care.
Hi, Dr. Ricky. Can I tell you about a patient I just saw? I think she's going to need admission.
Sure.
Anna is a 17-and-a-half-year-old Aboriginal female who's currently under the care of Child and Family Services. She's of no fixed address, as she's recently been kicked out of her group home for using drugs and aggressive behavior. She was brought to the Foothills ER with Calgary Police Services on a Form 10 after she was found in an alleyway with a GCS of 5. She's been medically cleared and stabilized by the ER staff and has been consulted to Psychiatric Emergency Services for our mental health recommendations. Anna is known to PES and mental health. Historically, she's been diagnosed with fetal alcohol syndrome, an intellectual disability, which on previous admission was assessed to be 58. She has a moderate opioid use disorder and has been noted to be oppositional defiant. She's currently under a guardianship order with CFS. Her guardian is aware of her presentation and is advocating for admission for some substance use treatment and to begin the transition to adult services. Anna was placed in CFS care when she was 14. After a 1-year admission to Foothills Unit 23, she was discharged to the group home where she was residing until recently. She last attended school 6 months ago, where she was enrolled in a modified grade 11 course. Anna describes school as difficult, noting kids pick on her because she has trouble understanding and her speech is slow. She hesitantly disclosed she's always felt awkward with her peers and she gets into a lot of altercations. Anna has not been on any medications since her discharge from Unit 23. She was to follow up with psychiatry in the community. However, her case was closed when she no-showed 5 times. While in the ER, she's been provided olanzapine with effect for her paranoia and objective evidence of auditory hallucinations. She's also quite agitated. Sadly, her prior history indicates she was raised by relatives who sexually trafficked her throughout Western Canada. Her parents were addicted to illicit substances and alcohol, and her mother murdered her father when she was 5. All her elder family members were sent to residential schools. When she spoke about her sexual abuse history, she was very flat and shrugged it off, stating, "It's normal for all the girls I know." She did say she might want to talk to somebody about it, but not me. She did not wish to complete the Adverse Childhood Experiences questionnaire. However, I was able to identify a score of 12, even though she refused to discuss this with me. Anna presents as disheveled and appears older than her stated age. She's short and slim in stature, with shoulder-length brown curly hair, wearing hospital attire. She's difficult to engage and appears withdrawn with poor eye contact. She denies perceptual disturbances. However, she appears to be responding to internal stimuli, which is evidenced by her looking at the wall and stating, "Screw off, I'm talking to the nurse." When male ER staff attempt to assess her, she's very hostile and aggressive. She constantly tells staff that she's feeling better and wants to leave. She's unable to provide a safe discharge plan. Her presentation is incongruent with her statements. Upon assessment, she notes she must have gotten a hot shot, but she's endorsing a strong desire to live. She admits that she has a problem with illicit substances, and she discloses that she's recently begun using intravenous heroin, and to support this, she's found herself a pimp. She's hesitant to discuss information about her pimp, but appears scared of what he will do if she's admitted to hospital. Of note, she's concerned about communicable diseases and asks about her HIV status. She's receptive to discussing harm reduction methods in the community. Her lab work, her urine drug screen was positive for opioids and marijuana. Her blood alcohol was 59 millimoles per liter on admission. She's MRSA positive. Her HIV results are still pending. Her blood glucose was 32. Her white blood cells and neutrophils are elevated. All other lab results were unremarkable.
Were you able to get collateral from Anna's family services worker?
Yep.
Could you tell me some more?
Oh, right. Sharon tells me the group home has noticed a change in her presentation where she began missing curfew, was tardy at school, and had become increasingly violent about 7 months ago. They now suspect she's using illicit substances and note she has a new boyfriend who's been coming in to her prior to entering the home. Her presentation change began approximately 6 months ago when she stopped attending classes. At this time, they noticed she'd become increasingly paranoid and appeared to be experiencing auditory hallucinations. Shortly after, that's when they noticed the illicit substance use. They believe she met her boyfriend approximately 4 months ago. She was kicked out following the third physical altercation with a male group home worker who approached her about her substance use. In his attempt to set boundaries, Anna became quite enraged and approached him with a kitchen knife. She is unable to return to this group home if she continues to use illicit substances. Sharon is asking that she be admitted to hospital for assessment of a new onset of psychosis, for stabilization, to discuss harm reduction for her substance use and sexual behavior, along with planning preparation for her transition to adult services.
Okay, I will see her right now. I've seen Anna and I feel she requires admission for the acute stabilization. This will support the guardian's request and enable time to plan for the transition to adult services. I also wonder about her psychosis. Is this new?
Sounds like it is. Currently, the adolescent units are full, with 10 plus adolescents waiting in ERs. We've recently received a memo from Calgary Zone directors dictating she will be admitted to an adult unit. I'm going to have to call her guardian and make sure that's okay. Her treatment plan has been identified as follows. She'll be admitted to an adult general psychiatric unit for stabilization and connections to Arnica. She'll be provided education around harm reduction, and we hope they'll consider Suboxone. She'll begin motivational interviewing. At this time, she's noted to be pre-contemplative. There's hope that she'll be connected to Calgary Communities Against Sexual Abuse for counseling for her sexual abuse. Hopefully, she can engage in CBT to develop skills in problem solving and understanding in how her past is influencing her behaviors. We hope to explore Calgary Family Services housing that is concurrent capable. The Aboriginal liaison was consulted and came to see Anna in the ER. She's agreed that this was helpful, and the Aboriginal liaison has assured her they will continue to follow up with Anna when she's in hospital. She'll need some patient teaching around elevated blood glucose and her risk for type 2 diabetes. Measles and Sullivan concluded the activation of mu opioid receptors affect glucose intake and glycemic control. However, Measles and Sullivan note, opiate agonists like naltrexone are not associated with weight gain or glycemic dysregulation, while some evidence suggests buprenorphine behaves like naltrexone. Further research is indicated. We wish Anna well in her admission.
Good morning, Dr. Davis. This week I've been working with Anna. She was admitted to our unit after being found with a suspected opiate overdose. She has an extensive trauma history after being a victim of sex trafficking. I have confirmed with her previous group home that she is no longer welcome back and is currently homeless. Overall, Anna is beginning to become more engageable to our unit programming and cooperative to our care. This week, Anna and I have had lengthy conversations regarding her future. I've been using motivational interviewing with her to make some goals. She has informed me she's interested in participating in counseling for her trauma, and I've spoken to social work regarding possibly looking at CASA for outpatient counseling and possibly starting with one-to-one counseling with our therapist on the unit. I believe we can start addressing Anna's ACEs as we can unlock the underlying roots for her addiction and adverse behaviors.
That's a great point. I've already been discussing with social work about the referral process for CASA to see what we can do. She does have an extensive trauma history, and I've talked to Anna about providing supports for her.
Anna and I have been talking about her substance abuse. She states she is getting easily overwhelmed and has poor coping once she gets stressed. I was teaching her a little bit about distress intolerance and a variety of ways to develop same. I believe that since she has become more involved with the unit, she would be an appropriate candidate to start our CBT and DBT groups. This can help address her aggressive behaviors and distress intolerance and give her some healthy coping skills when she gets overwhelmed. I recently read that DBT programs have displayed benefits towards anxiety and depressed mood for PDD clients. With that in mind, maybe we can get Anna started on DBT and have a day hospital or psychosocial rehab set up for post-discharge.
Okay, I will put in the referral for Anna to begin CBT and DBT groups. Also, I will talk to her regarding possible day hospital program for Claire's Home psychosocial rehab to see what she would prefer, and then I will set up my referrals.
And lastly, although Anna has declined any form of residential treatment for her opioid use, she states she is wanting more information on Suboxone. I was thinking you can talk with her more about Suboxone treatment, and then as part of the discharge plan, we can have ODP consulted. If we have Suboxone and addictions follow-up with ODP for Anna, we will have a better chance to minimize or eliminate her substance use.
Okay, for sure. I'll arrange a meeting for me and pharmacy to talk with her about Suboxone, and I'll see what she thinks about having ODP involved.
Hello, Anna. How are you?
Hey, I'm good. How about you?
I'm good, thank you. Oh, it's so beautiful outside. I'm so happy we got to meet off the unit today.
Yeah, I'm so glad winter's finally over.
Oh, me too. Is Sharon here so we can go over some information for your discharge?
No, she's not.
Oh, that's okay. I'm gonna follow up with her a little bit later and tell her all the same information before you go. So just so you know, you're leaving under what's called the community treatment order. Do you know what that is?
No.
Okay, so a community treatment order is a legal order under the Mental Health Act, which is made by a psychiatrist or a physician that outlines the conditions a patient who's leaving psychiatric treatment, like you, must receive in order to be able to live in a community setting. It also allows the police to be able to bring you back should you kind of fail to comply or meet the requirements of your CTO. Your doctors and care team here have come up with this big plan for you, which we believe is feasible and that you can accomplish. In your case, it requires you to attend all meetings at the Arnica Center, all of your medical appointments, and remain abstinent from illicit substances.
So why am I on a CTO?
Well, in order to be on a CTO, 2 qualified professionals, in this case your doctor and another doctor, have decided that you meet the criteria, which is that you would likely decompensate in the community and likely cause harm to yourself or others. And since we saw these behaviors when you were admitted, it's really important for us to know that you're going to be getting the help you need.
So how long do I have to do it for?
Well, CTOs last 6 months. At that time, they can be renewed, but we can talk about that closer to that time. But in the meantime, I just want to talk about some other discharge requirements that are part of your CTO. So part of it is that you attend all medical appointments and counseling at the Arnica Center. The Arnica Center provides psychiatric assessment and consultation to adults and teenagers who are over 16 and have an intellectual disability and a mental health or behavioral problem. So the Arnica Center offers psychiatric assessment and stabilization via medication for individuals 16 years or older and who have an IQ of 70 or below before they turn 18. They also have mental health conditions and significant behavioral problems, and that they have a doctor that's supportive of the referral, which you do. Now, you may not fit all of these requirements, but it's important that you go. There will be staff there to support you, and we will help you with your transition. Now, the address is right here. I wrote it down for you. It is 3465 26th Avenue. I printed off the bus maps and the times and highlighted all the routes from both your group home and from school in order to show you how to get there. It's all in here. And also I've highlighted all the times that you need to be there during this upcoming week. We also have a bus pass for you. It's in here too. Arnica will provide you with another one in the upcoming months. I just want to talk about some harm reduction techniques in teaching. Do you know what harm reduction is?
I think it's to prevent bad things from happening when you do bad things.
Yeah, it's similar. It means that we're aware of some of the bad things that you do, such as engage in unprotected sex and substance use, and we just want to make sure, we want to help make those things safer for you if you choose to engage in them.
Oh, okay. Like giving me condoms.
Yeah, exactly. We can give you condoms and other safe sex supplies to prevent against both STIs and pregnancy. I've had them all in here for you. I've included some condoms for you, and we also set you up for an IUD appointment like we talked about the other day. Your caseworker is going to take you on Monday to get an IUD. The phone number for the clinic is in here. They're going to call you tomorrow to ask you a couple of questions and let you know what you need to do beforehand. Is that okay?
Yeah, that sounds great. Thanks for doing that. What if I run out of condoms?
Well, the youth clinic at Sheldon Schumer is a place that you're going to be getting your IUD, and they give them out for free along with lots of other safe sex supplies. You can always go there and get more, no questions asked. But when you go in there on Monday, the nurse can talk to you about all what they do there. It's a really great clinic. I want to talk to you about the opioid dependency program, which is what you're going to be a part of once you're discharged. Is that okay?
Yeah.
Okay, perfect. The ODP program provides methadone or Suboxone maintenance treatment to people dependent on opioids and helps them access services they need to live healthy lives. In your case, you're going to be taking Suboxone in order to help you get off opioids and engage in support, counseling, and treatments for your substance use. A doctor is going to be monitoring you while you take the medications and make sure you're doing well at home with them. That being said, we both know that recovery is not linear and slip-ups may happen. We encourage you to speak with a professional, but should you find yourself in a situation where you or another person is using opioids, but I want you to be aware of some overdose prevention and response tips. I want to give you this pamphlet that goes over how to recognize signs of an overdose, such as stopping breathing, turning blue, loss of consciousness, low heartbeat, seizures, or other odd behaviors. I want you to know that you should never use alone. Always use safe routes instead of injection, like oral or smoking. Never mix your drugs, know where they come from, and always carry an naloxone kit and how to use one and call for help. Do you know how to use an naloxone kit?
Yeah, that's like the first thing they teach in addict school.
Okay, just making sure you do, as it can save you or someone else's life. So here's a new one, along with the information sheet. You can go to any pharmacy to get one for free. It's confidential. I also give you a sheet on how to use it in case you forget.
Awesome. That's really helpful information.
Yeah, you're welcome. Now, your first appointment at the ODP clinic is next Tuesday. You're going to see Dr. Joe at 10:45. The bus routes and the passes for getting in there are all in here. It's super important that you go. It's part of your CTO. It's the best thing for you. We also made sure that there are staff at your new group home to be able to give you these medications as they're a controlled substance, as they also need to be monitored closely to make sure they're working, there's no side effects. So we've got that all under control. Do you have any questions about any of this?
I don't think so, no.
Okay, well, you can always call me if you do. I'm going to call you next week to follow up, and your doctor will be in to discharge you soon.
Okay, awesome. Thank
All
you very
right,
much.
bye.
Bye.
This case study was loosely based on a few of our patients we have worked with. We hoped you enjoyed our production. Making connections to resources for an adolescent experiencing mental illness and substance use disorder can be difficult, specifically when using resources providing harm reduction methods as opposed to those requesting the adolescent to be abstinent. As advanced practicing nurses, it is important we provide patient-centered care. We felt it was imperative to work with Anna where she was at while supporting her capacity to make better decisions. Additionally, offering harm reduction approaches and building stronger connections to community services will exponentially improve her health.